Hi everyone, good evening. So I am back with you so that I can discuss with you the part 2 of preterm labor. Now this was a very short notice which I had given, and so I don't expect many of you to watch live with me. But since I promised that I'm going to complete preterm labor, so here I am completing part 2 of preterm labor. Now, in part 1, I had discussed with you what are the risk factors for preterm labor and also the interventions which you should be doing, right? If a patient with preterm labor who has previous history of preterm labor or any risk factor related to preterm labor, if she comes to you, right? Now I'm going to discuss with you now. Forget about the risk factors, the history taking part where we discussed all those things. What are the risk factors related to preterm labor, and on history what you have to do. Now let us see, this patient has come to you, you have taken the appropriate history. Now what are the problems with this, with which the patient is going to present to you? So please remember that a patient of preterm labor, she is going to come to you with complaints of menstrual cramp like pain, or she can come to you with low backache, with pressure symptoms, or vaginal discharge. Now, whenever there is preterm labor, patient will be experiencing uterine contractions, right? And all of you know that uterine contractions can be felt in normal labor as well, and it could be the true labor pains, and it could also be a false labor pains. So how, as a resident or how, as a doctor, are you going to know whether you are dealing with true labor pains, that is preterm labor, or whether this patient is having false labor pains? And this is something which you know from your undergraduate knowledge, that true labor pains, they are progressive and they are associated with cervical dilatations. If you are a marrow subscriber, then also you know this, because always I have been stressing on these two very important points which help you in distinguishing true labor pains from false labor pains, apart from so many other things. The two very important ones are, number one, true labor pains are progressive. What do you mean by they are progressive? They will increase in intensity, they will increase in frequency, and they will increase in strength as the time is going to pass. And number two, they are associated with cervical dilatation, right? Now, we have done all the history related points, that what all is important when you are taking history of a patient of preterm labor. Now, examination. So, such a person, such a patient who comes to you with these complaints, history taking, I have told you. Now, in examination, what is important? In examination, the first thing which is important is the vital signs. Why are vital signs so important when we are talking about preterm labor? Number one, why vital signs are important is because one of the very important reasons for preterm labor is abruptio. Right? So you have to rule out abruptio. You have to, because in abruptio, the bleeding is going to be less, but patient may be in shock, right? So in patients of preterm labor, while you are examining them, vital signs become very important, because number one, I want to rule out abruptio in them. Number two, vital signs are important. I want to check fever in them, because so many times preterm labor is associated with premature rupture of membranes, and premature rupture of membranes can lead to chorioamnionitis. That is why checking their vitals, checking their temperature, their pulse rate, their BP becomes very, very important, right? Then in these patients, the next thing what I'm going to do is I'm going to do a per abdominal examination. A per abdominal examination to assess the gestational age, because just now when I'll be talking about management, I'll be telling you that there will be females in whom the preterm labor will be happening at less than 34 weeks, the management will be different. And if preterm labor is happening at more than 34 weeks, management is going to be different. That is why I have to assess their gestational age, although the best method to assess gestational age is first trimester ultrasound. So I am going to ask them for their first trimester ultrasound. so that I can come to know their exact gestational age. Apart from that, when I'm doing a per abdominal examination, I'll be assessing their gestational age, and I will be noting down how many contractions they are having. So how many contractions, what is the frequency of contractions, what is the duration of contractions, this is also something which I have to note in patients of preterm labor. Third thing is you should note the tone of the uterus. Why? Again, the tone of the uterus is important because in abruptio, uterus will be tense, tender and rigid. So you should note the tone of the uterus. And number 4, you should know about what is the lie, what is the presentation of the fetus. So do a Leopold's maneuver and check all these things. So when you are taking history of preterm labor, the points which were important, I told you. Now you are going to examination in a patient of preterm labor. On examination, the general examination, what are the important things which you have to keep in mind? On per abdominal examination, what are the things which you are going to assess? Now when you are doing a per abdominal examination, you also have to auscultate their fetal heart sounds, which is very, very important. And you should see whether the fetal heart sounds are regular or not, whether they are between 110 to 160 beats per minute or not. Right? Now, after per abdominal examination, do not jump to per vaginal examination. First thing what you're going to do is a per speculum examination. Again, why? Because preterm labor is associated so many times with premature rupture of membranes. And before I rule out premature rupture of membranes, I am not going to go to a per vaginal examination. So first thing is do a per speculum examination and see whether the membranes are ruptured or not. So you should know whether premature rupture has happened or not. Right? So if you can see the amniotic fluid coming out from the internal os, or if you're from the introitus, or if you can ask the patient to cough, and if on coughing there is pooling of amniotic fluid which is happening, then you come to know that yes, the membranes are also ruptured. Right? Number 2, when I'm doing per speculum examination, I am going to assess the dilatation of the cervix. How much is the cervix dilated? That is what I am going to assess. Number 3, I am also going to assess bleeding. I want to see whether this patient is having preterm labor due to abruptio, or she's having preterm labor due to placenta previa, because vaginal bleeding can also trigger preterm labor, right? So when I'm doing a per speculum examination, I am assessing bleeding also. And fourth thing, when I'm doing a per speculum examination, I am going to obtain a cervico-vaginal swab. Now, please do not say that a cervico-vaginal swab is for group B GBS, to screen for GBS. A cervico-vaginal swab is not a method for screening for GBS. This cervico-vaginal swab which I am taking is for fetal fibronectin. I want to see whether fetal fibronectin is present in vaginal fluid or not, right? And in order to obtain this swab, you are going to take the swab from the posterior fornix and you're going to rotate it in the posterior fornix for 10 seconds, and then you are going to take a cervico-vaginal swab. So these are the 4 things which you're going to do when you're doing a per speculum examination. You're going to rule out premature rupture of membranes. You're going to assess the dilatation of the cervix. You are going to see whether any bleeding is present or not. And you are going to obtain a cervico-vaginal swab for fetal fibronectin. Clear to all of you? Fetal fibronectin protein, the swab has to be taken from the posterior fornix after rotating for 10 seconds. Apart from that, other than that, I'm going to take a recto-vaginal swab. And this recto-vaginal swab is a method of screening for group B streptococci. Now, when you are taking a recto-vaginal swab, please remember that the swab has to be taken from lower vagina, just above the vaginal introitus. or at the level of vaginal introitus and not a high vaginal swab. That's a very common mistake which you tend to do when you say that we are going to take a rectovaginal swab from high vagina, right? It's not that. You have to take rectovaginal swab from lower part of vagina near the introitus and from the rectum. When I say you have to take swab from the rectum, that means 1 centimeter above the anal sphincter. Now, when you are taking a rectovaginal swab, either you can take two swabs, one from vagina and one from rectum, or the same swab can be used for vagina and rectum both. And once you've taken the swab, you have to place it in a non-nutrient transport media like a Stewart media. Right, so a non-nutrient transport media, you have to put it in it, and in the room temperature or at room temperature only you have to transfer it. So you don't need any kind of lowering down of temperature or any kind of fridge for doing that, right? Or you don't need to put an ice pack for transferring the media, right? So it has to be done at room temperature, and this culture, group B streptococci culture is going to be done for 48 to 72 hours. So I am going to get the report after 48 to 72 hours, right? Clear. So this is what you do when you take a rectovaginal swab. Now comes per vaginal examination. Now, after a per speculum examination, I'm going to do a per vaginal examination. But please remember, in patients of preterm labor, you have to rule out two things before you go for a per vaginal examination. Number one, rule out premature rupture of membranes, because if membranes are ruptured, we never do a per vaginal examination or a digital examination because of the risk of introducing infections. And number two, you will have to rule out, when you are doing a per vaginal examination, you have to rule out placenta previa. See, bleeding in pregnancy can precipitate preterm labor, right? So placenta previa and abruptio both are risk factors for preterm labor. So if a patient is coming to you with preterm labor and she is also having some bleeding, before you do a per vaginal examination, please rule out placenta previa and please rule out premature rupture of membranes. The best way of ruling out placenta previa is to look at her third trimester ultrasound, right? So you are going to ask her for a third trimester ultrasound. If she doesn't have a third trimester ultrasound, you are going to do a screening ultrasound for placenta previa, and the screening ultrasound for placenta previa is a trans-abdominal scan. The investigation of choice for placenta previa is a transvaginal scan, but to screen placenta previa, you have to do a trans-abdominal scan. Right? Now, what are the lab tests which you are going to send in a patient of preterm labor? Number one, do not forget to send a urine routine microscopy, because so many times patients will be having asymptomatic bacteriuria, and it is this asymptomatic bacteria which might have led to preterm labor. Number two, as I said to you, you are going to take a swab for fetal fibronectin. Please remember the best, conditions the mandatory conditions in which fetal fibronectin swab has to be taken, a cervicovaginal swab for testing fetal fibronectin, it should be taken is when a patient comes to you with preterm labor at less than 34 weeks and the dilatation of the cervix is less than 3 centimeters and length of the cervix is between 2 to 3 centimeters. See, what happens is, just now when I'm going to talk to you next about the diagnosis of preterm labor, I will tell you that instantly you can make a diagnosis of preterm labor if a patient is coming to you with uterine contractions and if length of the cervix is less than 2 centimeters or dilatation is more than 3 centimeters. Now, in all those cases where we are in doubt, where the dilatation is less than 3 centimeters and the length of the cervix is between 2 to 3 centimeters. So in this patient, I'm in doubt whether she is in preterm labor or not, and it is these cases which are the best for taking out swab for fetal fibronectin protein. Because in this category of patients, if your fetal fibronectin protein comes out to be positive, then you come to know that yes, this patient is having preterm labor. Right? Clear? Okay. And third investigation is a recto-vaginal swab for group B streptococci. So these are the three investigations which you should be doing whenever a patient comes to you with preterm labor, right? Now, for the diagnosis of preterm labor, how do you diagnose preterm labor? For diagnosis of preterm labor, patient should be having uterine contractions, right? So the patient should be having uterine contractions more than equal to 4 every 20 minutes or more than equal to 8 in 60 minutes. So either 4 contractions in 20 minutes or 8 contractions in 60 minutes, then we say that this patient is having uterine contractions. And along with this uterine contractions, any one of the following should be present. So uterine contractions plus either the dilatation of the cervix more than 3 centimeters, so more than 3 centimeters, more than equal to 3 centimeters dilatation of the cervix, or length on TVS less than equal to 2 centimeters, or if length is between 2 to 3 centimeters, then a positive fetal fibronectin protein. That is why I told you that if length of the cervix is between 2 to 3 centimeters and dilatation is less than 3 centimeters, definitely you should be taking a cervico-vaginal swab for fetal fibronectin proteins. And I know that in your colleges, in your medical colleges, you are not doing that. You are not taking out swabs for fetal fibronectin protein. And I really doubt whether you are taking out recto-vaginal swabs also or not. So if you complete this lecture later on, and if you are listening to me, in the comment box, do let me know the protocol which is being followed in your colleges. Are you people taking out swabs for group B streptococci culture, and are you people taking out rectovaginal swabs for fetal fibronectin protein or not? Right? Do let me know that. But the guidelines say you should be doing that, right? So how do you diagnose preterm labor? Diagnosis is made clinically. Number one, if the patient is having uterine contractions and any one of the following. So uterine contractions with either dilatation of the cervix more than 3 centimeters or length of the cervix less than equal to 2 centimeters, or if length is between 2 to 3 centimeters, then a positive fetal fibronectin protein. A very, very important thing which I want to tell you, which as undergraduates also you were confused, was the length of the cervix. Please remember that on TVS, to predict that yes, preterm labor is going to happen, the cutoff length was 2.5 centimeters. Right? So if the length of the cervix was 2.5 or less, we used to predict that yes, this patient has chances of preterm labor. But to detect preterm labor, the length is less than equal to 2 centimeters. If it is between 2 to 3 centimeters, then it should be accompanied with a positive fetal fibronectin protein. Right? Okay, so a few very important points on fetal fibronectin protein which you may be asked during your viva or in your exams. So what is fetal fibronectin protein? Fetal fibronectin protein is an extracellular matrix protein. Right? It's an extracellular matrix protein which is present at the decidual chorionic interface. And whenever this decidual chorionic interface is, broken or disrupted, then this fibronectin protein is released in cervicovaginal secretions, right? So it is a protein, it is an extracellular matrix protein which is present between the decidua and the chorion. And whenever this interface is disrupted due to any reason, and that reason could be infection, right? It could be inflammation, that could be due to abruption, or that could be due to uterine contraction. So due to any reason, if this interface is disrupted, it is going to result into fetal fibronectin protein coming inside the cervicovaginal secretions. Please remember that fetal fibronectin protein can help in predicting preterm birth as well. Because if fetal fibronectin protein is present in cervicovaginal secretions, that means there is an increased risk of delivery in the coming 7 days. Right? So it can predict preterm birth also, and it can be used in the diagnosis of preterm labor also. So now again I'm telling you, every preterm labor doesn't end in preterm birth, right? So this is used as a diagnosis for preterm labor, right? And it can predict that this preterm labor can end up in preterm birth in next 7 days, right? Now, a positive fetal fibronectin, what do you mean by that? A positive fetal fibronectin protein means a concentration of more than equal to 50 nanograms per ml, right, in cervicovaginal fluid between 22 weeks to 34 weeks in women with intact membrane where the dilatation is less than 3 centimeters and there is no gross bleeding. So in all those patients where membranes are intact, in all those patients where dilatation is less than 3 centimeters, in all those patients where there is no bleeding, why am I ruling out these things? Because abruption can also lead to an increase in cervicovaginal an increase in fibronectin in cervicovaginal fluid, right? So if there is no bleeding, if the membranes are not ruptured, and still if you are getting fetal fibronectin more than equal to 50 nanograms per ml in cervicovaginal fluid, that means this patient and the dilatation is less than 3 centimeters, then that means this patient is experiencing preterm labor, and that means many of them may go into preterm birth in next 7 days, right? Okay. Now, how do you manage a case of preterm labor? Now, for management of preterm labor, please remember that we are dividing these patients into two categories as per ACOG. If you remember in preterm, in lecture 1, I told you ACOG said that early preterm labor and late preterm labor. Early was if it was happening at less than 34 weeks, and late was when it was happening at more than equal to 34 weeks. So the management is based on this classification only. So if a patient comes to you with preterm labor at more than equal to 34 weeks, what are you going to do? Number one, you are going to admit the patient and you are going to observe her for 4 to 6 hours. That is one thing which you have to do. Number one. Number two, please remember that the new guidelines say that corticosteroids should be given in all these patients also. ACOG says that corticosteroids should be given. It has to be given at less than 34 weeks. That's fine. So at less than 34 weeks, all guidelines, they say that corticosteroid should be given. So when I am going to tell you about how to manage preterm labor at less than 34 weeks, I'm going to tell you that all the guidelines say that yes, corticosteroids should be given at less than 34 weeks. But when it comes to preterm labor beyond 34 weeks, then ACOG says that corticosteroids should be given from 34 weeks to 36 weeks plus 6 days, whereas NICE guidelines say that it should be given if preterm labor is happening between 34 weeks to 35 weeks plus 6 days, right? So now the newer guidelines, although still in your hospitals you will see that many of the clinicians, they don't give corticosteroid if preterm labor is happening beyond 34 weeks. But now the guidelines say that if preterm labor is happening even beyond 34 weeks, you should be giving corticosteroids. And exactly I have told you the guidelines, what ACOG guidelines say and what NICE guidelines say. ACOG says that between 34 weeks to 36 weeks plus 6 days, you should be giving corticosteroid if preterm labor is happening between this time. NICE guidelines say if preterm labor is happening between 34 weeks to 35 weeks plus 6 days, then you should be giving corticosteroids. But then all the guidelines agree to this, that at this time there is no role of tocolytics. Right? So you are going to admit the patient, you are going to observe the patient for 4 to 6 hours, you are going to give her corticosteroids, you are not going to give tocolytics, and you are going to assess fetal well-being. How are you going to assess fetal well-being? By doing an NST and a biophysical score, and you are going to rule out abruptio. So whenever a patient of preterm labor comes to you, please do not forget to rule out abruptio. Rule out chorioamnionitis and rule out premature rupture of membranes. So, because if it is a case of abruptio, management will be different. If a chorioamnionitis is there, management is going to be different. If PROM is there, management is going to be different. So I am going to see that there is no abruptio, no PROM and no chorioamnionitis. And I'm going to give GBS prophylaxis. Yes, that's very important. ACOG now says that in all patients who come to you with preterm labor, you should give them GBS prophylaxis. So your next question is going to be that, ma'am, in all patients, if we are giving GBS prophylaxis, then why are we doing screening for GBS infection when a patient of preterm labor comes to you? So yes, bachcho, remember this, that when you are patient of preterm labor comes to you, you are going to take out a recto-vaginal swab for GBS infection, for screening for GBS infection, and simultaneously once you've taken out the swab, then you are going to start GBS prophylaxis, because the result of the screening, as I told you, culture takes 48 to 72 hours. So till 48 to 72 hours, I'm going to continue with them the GBS prophylaxis. Now, once the result comes and if my patient is said to be positive, I will continue the antibiotics. If the result says that the result is negative for GBS, then I'm going to stop the antibiotics, right? So that is the new protocol which has come, that all patients who come to you with preterm labor, you should be giving them GBS prophylaxis, right? Now, in these 4 to 6 hours, after I have done all this, after I have given her corticosteroids, I have, given her, I have assessed her fetal well-being, I have ruled out PROM, I have ruled out chorioamnionitis, abruptio, I have started antibiotics, and if I see that there is no progressive dilatation and effacement, because all of you know that true labor pains are associated with progressive dilatation and effacement, and if I see that no, she's not having any progressive dilatation and effacement, I'm going to send her back home and I'm going to tell her that come to me after 1 to 2 weeks, right? So you can send the patient back home after 4 to 6 hours if there is no progressive dilatation and no effacement, right? Now, you are going to tell your patient to come back to you after 1 to 2 weeks, but then you are also going to tell her the red flag signs, those signs when she should come to you immediately. For example, if she experiences signs of symptoms of preterm labor again, she should immediately come back to you. Or if she experiences any bleeding, she shouldn't wait for 1 to 2 weeks. She should immediately come back to you. If she has decreased fetal movements, she should immediately come back to you. Or if the membranes rupture, then she shouldn't be waiting for 1 to 2 weeks. She should immediately come back to you. So you have to tell these things into your patient and you have to mention them on the discharge card, that if she is experiencing signs and symptoms of preterm labor, if there are decreased fetal movements, if membranes rupture, or if bleeding happens, she should come to you immediately. Otherwise, she should follow up after a week, right? So just now I told you 3 very important things. The first important thing which I told you is that corticosteroids are now recommended in preterm labor between 34 weeks to 36 weeks plus 6 days. That is one very important thing. The other very important thing about corticosteroids you should know is that ACOG says that if any female is undergoing cesarean section for any reason, right? For any reason, if a female is undergoing cesarean section at less than 37 weeks, again, that is an indication for corticosteroid, right? So suppose your patient was having placenta previa, and due to some reason you told her that I'm going to operate you at 36 weeks of gestation. So in this patient also, because you are going to do a cesarean section before 37 weeks, still it is an indication for giving corticosteroid, right? The third important thing which you have to remember is that ACOG says that all patients who are in labor at less than 37 weeks, that means they are in preterm labor, they should all be given GBS prophylaxis, right? So these are three things which you have to remember in terms of the new guidelines. Number one, corticosteroid should be given to all patients who are coming to you with preterm labor between 34 weeks to 36 weeks plus 6 days. Number two, if due to any reason, if you are doing cesarean section at less than 37 weeks, then definitely you have to give corticosteroids. And number three, in all patients of preterm labor, you have to give GBS prophylaxis. Right? So, have I made myself clear? Yes? But I am here to explain to you preterm labor just now. Right? And this class is specifically for NEET PG, not for NEET PG. This is specifically for residents of OBGY, for DNB students of OBGY and NEET superspeciality. So if in the live chat box you're going to write to me about any other queries which are unrelated to the topic, I'm not going to answer them just now. Right? If you have any queries related to the topic, you ask me, I will be very happy to solve your those queries. Right now, whether I'm coming to Bishkek or not, what is asynclitism, what is synclitism, all this I'm not going to answer in this live session just now. Right? So any queries, any doubts which you have related to preterm labor till now? Okay. So I'm proceeding. Now, now let us talk about corticosteroids. That's very, very important. Right? So corticosteroids or antinatal corticosteroids, why I have written this is because so many places I'll be writing ACS. So you should be knowing what is ACS. Now, what is the role of ACS? Why is its advantages? Number one, if you are giving corticosteroid in a patient of preterm labor, it will decrease the chances of transient tachypnea of newborn. It is going to decrease respiratory distress syndrome and it is going to decrease mortality in a patient of preterm labor. Mortality is perinatal mortality. Right? Apart from that, it is going to improve circulatory stability in a preterm neonate, and because it is going to increase circulatory stability, it is going to decrease the chances of intraventricular hemorrhage and necrotizing enterocolitis. So when I'm giving antenatal corticosteroids, I am not just aiming at decreasing transient tachypnea of newborn and respiratory distress syndrome. I'm also aiming at decreasing intraventricular hemorrhage and necrotizing enterocolitis. Right? Now, what does ACS do, or antenatal corticosteroids, what do they do? Antenatal corticosteroids, they accelerate the development of type 1 and type 2 pneumocytes. Now, because they accelerate the development of type 1 and type 2 pneumocytes, they will increase the production of surfactant, number one. Number two, they will induce pulmonary beta receptors, right? So they are going to induce pulmonary receptors, and it is these pulmonary receptors which play a role in the release of surfactant. So number one, they are increasing production of surfactant. Number two, they are helping to increase the release of surfactant by increasing pulmonary beta receptors. Number three, they induce fetal lung antioxidant enzymes. So the antioxidant enzymes which are present in fetal lungs, it will induce the formation of those antioxidant enzymes. Apart from that, it will upregulate the genes which promote sodium liquid absorption of pulmonary epithelium, right? So that is how it's going to decrease, the pulmonary edema also. So it is going to promote the absorption of sodium and liquid which is present at pulmonary epithelium. So these are all the ways by which antenatal corticosteroids, they help in decreasing respiratory distress syndrome and in transient tachypnea of newborn. Right? Now, when we talk about efficacy of antenatal corticosteroids, please remember that the moment you give antenatal corticosteroid injection, within a few hours of the injection, effect is going to begin. But maximum efficacy or best efficacy is seen between 2 to 7 days after administration of the first dose. So although some effect will be seen the moment you give the injection, within few hours some effect is going to come. But best results are going to be seen when 2 to 7 days after the first dose. So suppose you have a female who's in preterm labor and she is at preterm labor at 35 weeks, right? Now, at 35 weeks, you give her corticosteroid and within 24 hours of giving corticosteroid, she delivers. Now, it is seen that if suppose a female has received only one dose of corticosteroid and then she delivers, then the outcome of the infant is still better than those who didn't receive even that one dose. Right? So even if that is why all these changes have come, that now when we say that you can give corticosteroids after 34 weeks but do not give tocolytics. So even if mother is having uterine contractions beyond 34 weeks and you are giving corticosteroid without giving tocolytics, which is not recommended beyond 34 weeks to give tocolytics. So even if she delivers and she hasn't completed the course of corticosteroids, still the outcome in the baby is going to be better than those mothers who did not receive even a single dose of corticosteroid. Clear to all of you? Now, when it comes to choice of corticosteroid, antinatal corticosteroid, you have got two of them. Either you can give betamethasone 2 doses 12 mg 24 hours apart, or you can give dexamethasone 4 doses 6 mg 12 hours apart. Now, why only these two are preferred? Because they are less extensively metabolized by the placental enzyme. Which placental enzyme? 11 beta hydroxysteroid dehydrogenase. So this enzyme, which is present in the placenta, it metabolizes the corticosteroid. But these are two corticosteroids which are less extensively metabolized by this enzyme, and that is why they will have maximum fetal effects. Any corticosteroid which is maximally metabolized by this enzyme, its availability to the fetus will be less. Now, because these enzymes are less broken down by this enzyme, because these two corticosteroids are less broken down by this enzyme, that is why the bioavailability to the fetus is more. And that is why you have to choose between dexamethasone and between betamethasone, right? Now, the T half of corticosteroids, betamethasone and dexamethasone, is between 35 to 54 hours. The betamethasone which we are using, 1 ml of betamethasone, right? So, 1 second. Now, this 1 ml of betamethasone suspension, it has got 3 milligrams of betamethasone sodium phosphate and it has got 3 milligram of betamethasone acetate. The salt betamethasone sodium phosphate is soluble and rapidly absorbed. That is why the rapid action of betamethasone happens because of this salt, right? And the salt betamethasone acetate is relatively insoluble. So the sustained effect is because of betamethasone acetate. The rapid action, the rapid onset of action is because of betamethasone sodium phosphate. And the sustained action is because of betamethasone acetate. Right? And that is why betamethasone has to be given after 2 doses have to be given, and the time and duration between those 2 doses is 24 hours. Right? Because it has got a sustained action due to betamethasone acetate. On the other hand, dexamethasone has dexamethasone sodium phosphate. This dexamethasone sodium phosphate has rapid onset and a shorter duration of action. That is why dexamethasone, you have to repeat dexamethasone 12 hourly and you have to give 4 doses. Right? 6 mg, 4 doses, 12 hourly, because dexamethasone sodium phosphate has rapid action and it has a shorter duration of action. So more doses are needed and shorter intervals are needed. Right? Now, what are the conditions when you have to give corticosteroid? What are the conditions where corticosteroid have to be given? So, number one, corticosteroid has to be given in preterm labor at less than 34 weeks. right? Then ACOG says that you should give to all patients who are having preterm labor between 34 to 36 weeks plus 6 days, but with the following caveats in your mind. What are the caveats? Number one, these patients should not be having chorioamnionitis, right? Number two, they shouldn't have received a course of sorry I'm so sorry. They shouldn't have received a course of corticosteroids earlier, right? So suppose there was a pregnant female, who had preterm labor at 30 weeks, right? At 30 weeks, you have given her a course of corticosteroid, and now she did not deliver, and she has reached 34 weeks. So in such patients, after 34 weeks, I am not going to give them corticosteroids. So if a patient has already received a course of corticosteroid earlier, then if she goes into preterm labor beyond 34 weeks, then I am not going to give her a course of corticosteroid. And third, whenever you are giving corticosteroid after 34 weeks, you have to monitor the neonates for hypoglycemia. So ACOG says that you have to give corticosteroids between 34 to 36 weeks plus 6 days. But number one, after ruling out chorioamnionitis. Number two, if you haven't given a course of corticosteroid earlier. And number three, in all these patients, the neonates should be monitored for hypoglycemia. Third thing, what ACOG says is that corticosteroids should be given. Antinatal corticosteroids should be given if cesarean section is being done at less than 37 weeks. So if for any reason you are doing cesarean section at less than 37 weeks, then also you have to give a dose of corticosteroids, right? Then there is something which is called as rescue dose or salvage dose or booster injection. So see, just now I told you that the maximum effect of corticosteroids, it is seen between 2 to 7 days. Just now we were doing that best efficacy is between 2 to 7 days, right? So suppose you have a patient of preterm labor in whom you had given corticosteroid at 28 or at 30 weeks, and patient did not deliver, right? So now the question is that if you have given a course of corticosteroid so early, then are you going to repeat another course of corticosteroid later before 34 weeks? So your example is patient received a corticosteroid, antinatal corticosteroid at 30 weeks, right? Now this patient at 32 weeks or at 33 weeks, am I going to repeat a course of corticosteroid? Before 34 weeks, am I going to do that? After 34 weeks, I'm not going to do that. But before 34 weeks, am I going to do that? So that is what is called as the salvage dose or the rescue dose or the booster dose. So ACOG says that you can give a single repeat dose of betamethasone, right? So not two doses, but a single repeat dose of betamethasone, 12 mg, in patients in whom all of the following characteristics are seen. So in those patients in whom you are getting all of these three things, you can give them a single repeat dose of betamethasone, not a complete course, but a single injection of betamethasone. And what are those three things which should be fulfilled? They should be less than 34 weeks of gestation, number one. Number two, there should be an imminent risk of preterm delivery within 7 days. And number three, the prior course of antenatal corticosteroid should have been given at least 14 days back, right? So please, again I am telling you, suppose you have a patient in whom you had given corticosteroid at 30 weeks, right? And this patient did not deliver. Right? So now my question to you is, at 32 weeks or at 33 weeks, am I going to give them a dose of corticosteroid? Yes, you can repeat a single injection of betamethasone. Number one, patient's gestational age should be less than 34 weeks, right? Then you can repeat. Number two, there should be a risk of preterm delivery happening in within 7 days there should be a risk of preterm delivery. And number 3, the prior course of antenatal steroids should have been given at least 14 days back. In that case, I can give them, a single course of betamethasone. Now, this recommendation is especially, this is not a mandate. These 3 things were mandatory to be fulfilled. Especially they say that suppose if you had given a corticosteroid injection before 28 weeks, then yes, it is a definite indication that now a single injection of betamethasone should be repeated. Right? So have you understood? I hope you are understanding when you can give a salvage course, a dose or a booster dose. Uh, Subhakant, this is not, some literatures, they do say that you may directly give a dose of 24 mg, but that is not supported by any study, right? So no study has supported it. All the studies say that suppose your patient is going to go into preterm birth is going to happen, then even if you've given a single dose of 12 mg betamethasone and if delivery happens, that's okay. The chances of respiratory distress syndrome in the baby are going to be less in comparison to if you did not give any injection. No study says that if preterm birth is about to happen, instead of giving 12 mg betamethasone, you give 24 mg betamethasone. No studies have supported that. No guidelines have supported that. So you have to remember the normal guidelines which ACOG have given, and this is what ACOG says. Right? Okay. Now, when you give corticosteroids, what are the maternal effects which you get? Now, number 1, whenever you give steroids, all of you know that if you are giving steroids, there will be a transient increase in glucose level, and that is going to happen even in pregnant females. Sorry. Even in pregnant females, this is going to happen, a transient increase in glucose levels. Right? So, what is the clinical implication of this? The clinical implication is, suppose I want to do a screening for gestational diabetes. Right? Now, ideally, the best time for screening for gestational diabetes is, we in India we do a DIPSI test where you do for in the first antenatal visit and then between 24 to 26 weeks. Now suppose you had told her that between 24 to 26 weeks you are going to come to me and I'm going to screen you for gestational diabetes. In the meanwhile, patient went into preterm labor, and because patient went into preterm labor around 24-25 weeks, you gave her corticosteroids, right? Now, if you've given her corticosteroids, after how much time, because antenatal corticosteroids will lead to an increase in mother's glucose levels. Now, after how many days of giving the corticosteroid injection are you going to test her for diabetes? Please remember, if you are giving corticosteroid injection and still you haven't screened the mother for gestational diabetes, either you screen her before you give a corticosteroid injection or you screen her after 5 days. So either screen her before you give corticosteroid injection or you do screening after 5 days. Right? Now, number 2, all those patients in whom you are giving corticosteroids, because it is increasing glucose levels. So suppose I have a diabetic patient. Now this diabetic patient will have polyhydramnios, and because of polyhydramnios she goes into preterm labor, right? Now tell me, because she has gone into preterm labor in a diabetic patient, will I give her corticosteroid or not? Because corticosteroid will temporarily increase glucose. So is hyperglycemia a contraindication for giving corticosteroid? No. Please remember that corticosteroids are not contraindicated in diabetics. So if you have a diabetic patient who goes into preterm labor and corticosteroid is indicated in her, I am going to give her corticosteroid. The only thing what I'm going to do is I'm going to monitor the glucose levels as well, right? So diabetes or hyperglycemia is not a contraindication for corticosteroids, right? Next important thing which you have to remember is corticosteroids, they have got very less mineralocorticoid action. So hypertension is not seen when you give antinatal corticosteroids. So again, hypertension is not a contraindication for giving corticosteroids, right? Number 3, when you give corticosteroids, the TLC of the female is going to increase by 30% within 24 hours and it is going to return to normal in 3 days. Again, this fact you should keep in mind because infections is also one of the predisposing factors for preterm labor. So if TLC is raised, it could be that this increased TLC could have happened before you've given corticosteroid, or this increased TLC could have happened after giving corticosteroid, right? Increased TLC, in other words, can also be seen during normal pregnancy. It can be a result of infection. It can be a result of giving corticosteroid injection. That is why TLC counts do not hold a lot of significance during pregnancy, right? Then please remember that there is slight increase in uterine activity, especially by beta-methasone, especially in twin pregnancies. So when you give beta-methasone in twin pregnancies, it is seen that there is slight increase in uterine activity. So these are all the maternal effects which are seen with corticosteroids. Now the fetal effects which are seen with corticosteroids are, corticosteroid, they can lead to decreased variability on day 2 or day 3. So if you are doing NST and you get decreased beat to beat variability, then that decreased beat to beat variability could be because of corticosteroids. Number 2, corticosteroids in the fetus can lead to decreased breathing and decreased body movements. In other words, you may get a lower biophysical score because of corticosteroids, right? So these are all the things which you have to keep in mind, that when you are giving corticosteroid injection to the mother, you may get decreased variability, beat to beat variability on CTG and NST, or you may get decreased biophysical score due to corticosteroids, right? Then corticosteroids, they are associated with neonatal hypoglycemia and with neurodevelopmental risk, but these risks are more if corticosteroid is given at an increased gestational age. That means if corticosteroids are given at more than 34 weeks, then these risks are more, right? The only contraindication for giving corticosteroid is chorioamnionitis. So if your patient has developed chorioamnionitis, then that's an absolute contraindication for giving corticosteroid, right? Chorioamnionitis is a topic which is taught with premature rupture of membranes. So if I keep on taking your lectures and if I teach you premature rupture of membranes, in that topic, definitely I'm going to take up chorioamnionitis, right? So this is how you manage a patient with preterm labor at more than equal to 34 weeks. Quickly, I'm telling you what you were doing at more than equal to 34 weeks. You were admitting the patient and you were observing the patient for 4 to 6 hours. You were giving them corticosteroids. There is no role of tocolytics. You are going to assess the fetal well-being by NST and biophysical profile. You are going to rule out abruptio, chorioamnionitis and PROM, and you are going to give GBS prophylaxis. And if there is no progressive dilatation of the cervix, then you're going to tell the patient to go back home and come to you after 1 to 2 weeks for follow-up. Right? There is no role of induction of labor. There is no role of tocolytics at more than equal to 34 weeks. Right? Now, if your patient is less than 34 weeks, now if the gestational age is less than 34 weeks, now what are you going to do? If gestational age is less than 34 weeks, again, I'm going to admit the patient. Again, I'm going to monitor this patient. What are you going to monitor the patient for? You're going to monitor the patient for the progress of labor, whether the labor is progressing or not, and for fetal well-being. Right? Then you are going to give steroids to these patients, antinatal corticosteroids. Now, as I told you, best efficacy for antinatal corticosteroids is between 2 to 7 days. So, in this category of patient, I want that at least corticosteroids should get 48 hours. So in these category of patients, I don't want them. They are very less gestational age, less than 34 weeks. So in this category of patient, I want full effect of corticosteroid, and full effect of corticosteroid will be seen between 2 to 7 days. That means at least 2 days. So I want that in this category of patient, delivery should not happen at least till 2 days after giving the first dose, because maximum efficacy of corticosteroid is seen between 2 to 7 days. So to buy time for corticosteroids to act, I am going to give them tocolytics, right? Please remember that tocolytics are to be given only and only for 48 hours. And why am I giving tocolytics? I am giving tocolytics so that I can get time for corticosteroids to act, right? Apart from that, in this category of patient also, you have to give antibiotics for group B streptococci prophylaxis, and also you have to give them magnesium sulfate for neuroprotection. Right? So two new things which you are going to do if a patient of preterm labor comes to you at less than 34 weeks. Everything is going to be same. Two things which are going to be different are you are going to give them tocolytics for 48 hours and you are going to give them magnesium sulfate. Please remember, magnesium sulfate should be given to all those females who are having preterm labor between 24 to 32 weeks. This magnesium sulfate is being given for neuroprotection. Right? Apart from that, whatever I was doing in preterm labor, which was happening at more than 34 weeks, I will do here also. I will send their urine routine microscopy. I will send swab for group B streptococci. Right? So all that I will be doing. But these two things new which I am doing are, I am giving them tocolytics for 48 hours and I am giving them magnesium sulfate. Right? Okay. Now, let's come to tocolytics. Now, in tocolytics, that is very, very important. You know, all the doses of tocolytics and what are the what are the mechanism of actions. All this is very important because you may get a short note on any one tocolytic or you may be asked about tocolytics in general, right? So, this is for all the PG residents. Now, tocolytics, number one important point is tocolytics, they should never be used for more than equal to 34 weeks of gestation. So, beyond 34 weeks, you are never going to use tocolytics, number one. Number two, tocolytics should not be used for more than 48 hours. You are going to use tocolytics only for 48 hours and not more than that. Why am I using tocolytics? I am using tocolytics to buy time for corticosteroid to act. Clear to all of you? This is the only role of tocolytics. Apart from that, there is no other role of tocolytics. You are taking time, you are buying time so that corticosteroids can act. Right? Now, choice of tocolytics. The first line tocolytics which are used are number one, nifedipine, which is a calcium channel blocker, and endomethacin, right, which is a COX inhibitor. Now, in India, the first line always or the drug of choice as a tocolytic is nifedipine. But this is not the case abroad where they follow ACOG guidelines. According to ACOG guidelines, between 24 to 32 weeks, so at less than 32 weeks, the tocolytic of choice is endomethacin. And between 32 to 34 weeks, the tocolytic of choice is nifedipine. Have you understood? In India, the tocolytic of choice is nifedipine. But this is not what ACOG says. ACOG says that at less than 32 weeks, the tocolytic of choice is endomethacin. Between 32 to 34 weeks, the tocolytic of choice is nifedipine. Why endomethacin is not used beyond 32 weeks is because it leads to premature closure of ductus arteriosus. That is why between 32 to 34 weeks, the tocolytic of choice is nifedipine. Right? So we have two first line tocolytics, number one endomethacin and number two nifedipine. In India, it is nifedipine. Right? Now, the second line tocolytics are terbutaline, which is a beta agonist, then atosiban, which is an oxytocin and vasopressin receptor antagonist. Then you have magnesium sulfate and nitric oxide donors like nitroglycerin. These are your second line tocolytics. Right? Now, coming to the details of tocolysis. So first we are going to talk in detail about nifedipine. Right? So I hope all of you are understanding this. See, I am going a little fast so that you understand quickly. And next time when you are listening to it, you can make your notes. Right? If you are able to write fast and you are able to make notes simultaneously, nothing like it. But if not, then this lecture is going to stay on YouTube and you can take down notes a little later. Okay? So, nifedipine. What is the mechanism of action of nifedipine? As I told you, nifedipine is a calcium channel blocker and it acts by various mechanisms. Number one, it is directly going to block calcium from coming inside the cell membrane, right? So it is directly going to block the influx of calcium ions, number one. Number two, this action is going to be blocked. Number two, so sarcoplasmic reticulum, so that it is going to block the release of calcium from sarcoplasmic reticulum, right? That is second mechanism. So it is blocking the release of calcium from sarcoplasmic reticulum. It is blocking influx of calcium ion, right? Third thing what it is going to do is, it is going to promote efflux of calcium ions. So it is preventing calcium ion from coming inside the cell. It is even blocking the release of calcium ion from sarcoplasmic reticulum. Then it is promoting the efflux of calcium ion. The net result of all these things is decreased intracellular calcium. And because there is a decrease in intracellular calcium, there are enzymes which are responsible for myometrial contraction. And what are those enzymes? Myosin light chain kinase. Now, this myosin light chain kinase is a very important enzyme responsible for myometrial contraction. And this myosin light chain kinase is a calcium dependent enzyme. So, if the levels of intracellular calcium are decreased, this myosin light chain kinase activity is decreased, because of which uterine contractions are decreased. Have you understood? Yes? So, that is what nifedipine does. It is decreasing the intracellular calcium levels, and because it is decreasing intracellular calcium levels, the myosin light chain kinase enzyme, which was dependent on intracellular calcium levels, which was a calcium dependent enzyme, that is not able to function, and because of which there is myometrial relaxation, right? Now, what is the loading dose of nifedipine? So you are going to give nifedipine orally, and initially you are going to give to the patient 20 to 30 milligrams of nifedipine, oral nifedipine. And then after every 3 to 8 hours, right, you are going to repeat nifedipine, oral nifedipine 10 to 20 milligrams. So initially I am going to start with 20 to 30 milligrams. Right? Clinically, आप अपने hospitals में देखोगे, you are going to typically start with 20 milligrams. Right? But guidelines say 20 to 30 you can start. And then you are going to repeat nifedipine after every 3 to 8 hourly, and you are going to repeat 10 to 20 milligrams. So what is followed in your hospitals generally is you start with 20 and then you increase up by 10 every day, every 3 to 8 hourly. Maximum in one day you can give 1 gram per day. Maximum nifedipine which can be given in a day is 1 gram per day, and you have to give it maximum for 48 hours. Right, maximum you have to give it for 48 hours, because all tocolytics maximum they have to be given for 48 hours. Right, now what are the side effects? The side effects are that it leads to vasodilatation. Now because it is going to lead to vasodilatation, patient may experience nausea, then there may be flushing, headache, dizziness, and palpitations. All these things are happening because of vasodilatory effect, right? What are the contraindications for using nifedipine? Number one, if there is heart failure with decreased ejection fraction. So if your pregnant female has heart failure with decreased ejection fraction, that is a contraindication. Number two, hypotension, because it leads to vasodilatation. So if your patient has hypotension, then that's a contraindication for using nifedipine, right? That was everything what you needed to know about nifedipine. Now coming to endomethacin. Now, all of you know that there are COX enzymes, and it is these COX enzymes which help in formation of prostaglandins, which have a role of converting arachidonic acid into prostaglandins. Now what endomethacin does is, endomethacin is a non-specific COX inhibitor, right? So it is going to inhibit the COX enzymes. We have COX-1 and COX-2, but it is a non-specific. I'm not saying it's a COX-1 inhibitor or a COX-2 inhibitor. It's a non-specific COX inhibitor, and that is why it is going to prevent the formation of prostaglandins. And in the first lecture, I told you that if prostaglandin levels are decreased, it is going to inhibit uterine contractions, right? Now, endomethacin, important point is, endomethacin is safe up to 32 weeks of gestation. So as a tocolytic, you can use it up till 32 weeks of gestation. The side effect of endomethacin, they are related, number one, to the gestational age at which they are used, and number two, to the duration for which it is used. And that is why endomethacin, it should never be used at more than 32 weeks of gestation, and it should never be used for more than 48 hours, because the side effects of endomethacin are related to two things. Number one, the gestational age at which it is used, and number two, the duration for which it is used, right? Then the dose of nifedipine which you're going to use, you can use endomethacin which you're going to use. Endomethacin, you can use it orally or parectally, and the loading dose will be 50 to 100 milligrams initially, and then you can repeat after every 4 to 6 hours, you can repeat 25 milligrams. So I'm going to initially give the patient 50 to 100 milligrams, and after every 4 to 6 hours, I can add 25 milligrams orally. 25 milligrams you're going to give her after 4 to 6 hours, right? And this you are going to continue every 4 to 6 hours till 48 hours, right? Now by chance, normally we do not recommend endomethacin to be used beyond 48 hours, but just in case you are using endomethacin for more than 48 hours, it becomes mandatory for you to do an ultrasound for evaluating oligohydramnios and for evaluating narrowing of the ductus arteriosus. Right? Clear to all of you? Now, what are the maternal side effects of endomethacin? Maternal side effects of endomethacin, they are like any COX inhibitor. So it is nausea, gastritis, gastroesophageal reflux, and because it's an antiplatelet drug, there could be platelet dysfunction. But most of the effects are nausea, gastritis, GI reflux, right? The fetal side effects are, number one, it promotes closure of ductus arteriosus. That is why it is never given beyond 32 weeks. And it can lead to decreased urine production in the fetus, which may lead to oligohydramnios. Right? Now, also remember these few lines about endomethacin. These were very important lines, and that is why directly I am showing you the screenshot. Neonatal complications linked with in utero endomethacin, they include bronchopulmonary dysplasia, necrotizing enterocolitis, patent ductus arteriosus, periventricular leukomalacia, and intraventricular hemorrhages. The associations are controversial, but what associations are confirmed? Association with closure of or narrowing of ductus arteriosus, that is one of the associations which has been confirmed. Neonatal renal failure has been attributed to in utero exposure to NSAIDs, but causality has not been established. Right? Renal impairment in these cases could have been related to prematurity and other factors. So, although yes, we have seen that neonatal renal failure has been associated with drugs like endomethacin, but because of that, no causality has been reported. Now, whether use of endomethacin has any long-term developmental effects, that is unclear, right? So, two things which are clear are, yes, it leads to oligohydramnios, it leads to closure of or narrowing of ductus arteriosus, right? But then others like periventricular leukomalacia, whether it is associated with it or not, intraventricular hemorrhage, necrotizing enterocolitis, all this has not yet been proved, right? Now, what are the contraindications for using endomethacin? So there are the normal contraindications which are with any other prostaglandin, with any other NSAID, and that is gastritis, right? So gastritis is one of them. Then liver disease, kidney disease, right? And any bleeding disorder, right? So these are the contraindications for using endomethacin. Then comes beta-2 agonist. Please remember that beta-2 agonists, they are no longer used for tocolysis, right? The only beta-2 agonist which is still being used is terbutaline, and it is basically used for uterine relaxation before you do external cephalic version. But yes, earlier beta-2 agonists, they were being used for tocolysis as well. Now they are not used because of so many maternal side effects with which they are associated. Right? Now, how do beta-2 agonists they act and how do they bring about tocolysis? That is, when you have beta-2 receptor agonist, they are going to act on beta-2 adrenergic receptors. And what these beta-2 adrenergic receptors do? They increase intracellular adenyl cyclase. They increase the activity of intracellular adenyl cyclase, and because they increase the activity of intracellular adenyl cyclase, whenever it is increased, it decreases the intracellular calcium levels. Right? So ultimately, all the tocolytic mechanisms, they are going to lead to a decrease in intracellular calcium levels. Beta-2 receptor agonist, they do it by increasing the activity of intracellular adenyl cyclase. Right? Now, because intracellular calcium levels are decreased, so myosin light chain kinase activity of enzyme myosin light chain kinase would be decreased, and that is why uterine contractions would be inhibited. Right? But the problem with beta-2 agonist is, over the time, target cells, they eventually become desensitized to the effect of beta agonist. And that is why the efficacy of beta agonist is decreased with prolonged use, that is tachyphylaxis happens. Right? Now, the dose of terbutaline for tocolysis is important, and that dose you are going to give terbutaline subcutaneously, 0.25 milligrams initially you are going to give, and you are going to repeat it every 20 to 30 minutes to a maximum of 4 doses to achieve tocolysis. Right? Now, once uterus has become quiescent, then you can repeat 0.25 mg every 3 to 4 hours. Right, so how are you going to bring about tocolysis? Initially, you are going to give terbutaline 0.25 mg subcutaneously, which you can repeat every 20 to 30 minutes so that the uterine activity stops. Maximum this you can do up till 4 doses. And once uterus has become quiescent, the uterine activity has stopped, then you are going to give again subcutaneous injections 0.25 mg every 3 to 4 hours. Now, terbutaline, it can be given in the form of subcutaneous injections or it can be given in the form of IV infusion also. Right, so the dose which you are going to give for IV infusion is 2.5 to 5 micrograms per minute, and after every 20 to 30 minutes you can increase by 2.5 micrograms. Maximum you can take it to 25 micrograms per minute. So maximum infusion which you can give is 25 micrograms per minute. Right, then comes the maternal side effects. Maternal side effects, beta 2 agonist, all of you know that it leads to vasodilatation, right? And because it leads to vasodilatation, there can be tachycardia. So it is going to lead to vasodilatation, which is going to lead to tachycardia, palpitations and hypotension, right? Apart from that, you may get hypokalemia and hyperglycemia. Rarely, in 0.3% patients, there may be pulmonary edema and rarely there may be myocardial infarction. Please remember that although it leads to hyperglycemia, but if diabetes is well controlled, then it is not contraindicated. But in our undergraduate times, we used to say that one tocolytic which is contraindicated in diabetic females is beta 2 agonist. But for you people, remember, if diabetes is well controlled, then you may give beta 2 agonist. Although I am telling you, beta 2 agonist, that is terbutaline, that's the only beta 2 agonist which is being used these days. They are not the first line tocolytic agents. First line tocolytic agent always will remain nifedipine or indomethacin, right? Now, the fetal side effects which you may get are fetal tachycardia, right? And you may also get hypoglycemia. Why hypoglycemia? Because in mother there will be hyperglycemia. This hyperglycemia is going to stimulate the fetus to produce more insulin, because you know that glucose is transported from the mother to the fetus. So whenever there will be maternal hyperglycemia, this glucose will come in the fetus and it is going to stimulate the fetuses to increase their insulin production, and ultimately it is going to lead to fetal hypoglycemia. Right? Now, what are the contraindications for using beta 2 agonist? Number one, if there is any heart disease in the mother with tachycardia, then this is contraindicated, right? Because beta 2 agonists, they themselves lead to tachycardia, so that may precipitate heart failure. Number two, poorly controlled diabetes or uncontrolled diabetes and poorly controlled hyperthyroidism. Right? So these are the conditions in which beta 2 agonists are contraindicated. You have to use beta 2 agonist with caution in patients with hemorrhage like placenta previa or abruptio. Why? Because beta 2 agonists, they are going to lead to tachycardia and hypotension, right, due to vasodilation effect. So this may interfere with mother's ability to respond to blood loss, right? So in patients with placenta previa and abruptio, you have to use beta 2 agonist very, very carefully, right? Because mother's ability to respond to blood loss may be interfered due to hypotension and tachycardia, which is brought about by beta 2 agonist. Now, whenever you are using beta 2 agonist in the mother, you have to monitor her heart rate and her BP. And if her heart rate becomes more than 120 beats per minute, then you should stop using this. Number 2, you should look out for shortness of breath and chest pain, and you should get her glucose levels and potassium concentration monitored every 4 to 6 hours. So these are the things which you are going to keep in mind whenever you are starting terbutaline in your patient with preterm labor. Monitor her heart rate, monitor her BP. If her heart rate becomes more than 120 per beats per minute, immediately stop it. Monitor her potassium levels, monitor her glucose levels. Look for any shortness of breath or chest pain which she might have. Right? Clear to all of you? Okay. Then comes atosiban. Atosiban generally, in India it's not available, so we definitely are not using it. I'm just giving you a few important points on atosiban to complete the discussion, right? So atosiban, what is atosiban? It's an oxytocin vasopressin antagonist. It is selectively available, right? So it's not available worldwide. In Europe, yes, it is available. In US, it is not available. In India, it is not available, right? And it is not FDA approved also. The mechanism of action of atosiban is it is going to compete with oxytocin to bind to myosin receptor to bind to oxytocin receptors in the myometrium and decidua. So it is going to compete with the oxytocin receptors, right? And it is not going to allow oxytocin to bind to its receptors. Please remember that normally when oxytocin binds to its receptors, there is an increase in intracellular calcium levels. Now, because atosiban is not allowing oxytocin to bind to its receptors, so the levels of intracellular calcium are going to decrease. And just now I told you that whenever intracellular calcium levels decrease, myosin light chain kinase enzyme is unable to function, and so uterine contractions are inhibited. That's one mechanism by which it acts. Number 2, because it is inhibiting oxytocin, so oxytocin is also responsible for producing PGF2 alpha, right? So it is going to inhibit the production of PGF2 alpha. Now, one point which I want to tell you is theoretically maximum action of atosiban should be seen near term. Why? Because oxytocin receptors and their sensitivity is maximum near term. Right? So theoretically, atosiban should be able to function only near term because atosiban is acting on oxytocin receptors. And oxytocin receptors, they are maximum near term. Right? Now, initial trials which were done in 2014, they showed that the activity of atosiban and of placebo, the result of atosiban and of placebo were same. Right? So earlier when the trials were done in 2014, they showed that if you are using atosiban in a patient of preterm labor and if you are using placebo in a patient of preterm labor, the results were same. Also, initial trials they showed that if you use atosiban, then this atosiban, it had got, fetal side effects, fetal death. It led to, if you used, they showed that atosiban, when it was used, it led to increased chances of fetal death. But later trials did not support this. Later trials did not support it. Right? So these initial trials which were done in 2014, they were the ones which said that the effect when you are using atosiban in patients of preterm labor and if you are using a placebo, the results are the same. So atosiban is not superior to a placebo. Right? And the initial trials also said that if you are using atosiban, it led to increased chances of fetal death. But then later trials did not support it. Right? So that is why atosiban is still used, or it is being used in Europe. In India and in US, it's not available. FDA has still not approved the use of atosiban. right? There are no maternal side effects of atosiban. There are no fetal side effects of atosiban. There are no contraindications of atosiban. Now, side effects of atosiban, they are just minor, no major side effects, only minor side effects like injection site reaction. Right? Only minor side effects like injection site reaction. That's the only thing which is seen. No other major side effects are seen. Right? Then, if they ask you what is the dose of atosiban, then the dose of atosiban is initially you have to give 6.75 mg IV bolus. This should be followed by 300 micrograms per minute infusion for 3 hours. Right, so this initially you give 6.75 mg IV bolus, then you should follow it up with 300 micrograms. I'm writing it clearly so that you can see properly. 300 micrograms per minute infusion for 3 hours, and then 100 micrograms per minute infusion for 45 hours. Right? So initially 6.75 mg IV bolus, then that has to be followed by IV infusion 300 micrograms per minute, and then 100 micrograms per minute infusion for 45 hours. Right? Now, magnesium sulfate. Please remember that magnesium sulfate also has weak tocolytic activity. In eclampsia, all of you know that the therapeutic range of magnesium sulfate is 4.7 milliequivalents per liter. Right? Now, as a tocolytic, it is 9 to 10 milliequivalents per liter. So, magnesium is going to act as a tocolytic when its concentration is 9 to 7 milliequivalents per liter. And that is why it is not preferred, because at 9 to 10 milliequivalents per liter, you are going to get the side effects. Right? Patient is start going to have diaphoresis, slurring of speech, deep tendon reflexes are not going to be there. They are going to be absent. So patient will start experiencing side effects. That is why magnesium sulfate is not used as a tocolytic, although it has got weak tocolytic activity as well. Now, what are the conditions in which magnesium sulfate is contraindicated? Number one, it is contraindicated in patients of myasthenia gravis. Number two, in those patients who have cardiac conduction defects. Number three, if they have myocardial compromise or myocardial infarction. That these are three very important contraindications of using magnesium sulfate: myasthenia gravis, then cardiac conduction defects, and myocardial compromise. All those patients who have history of myocardial compromise or myocardial infarction. Please remember, you should never use magnesium sulfate with calcium channel blockers, because magnesium sulfate also blocks calcium channels. So if you are using calcium channel blocker and magnesium sulfate together, it can lead to respiratory depression. Right? Now, as a tocolytic, just in case you have to use magnesium sulfate, then what is the dose? So whenever you are using magnesium sulfate as a tocolytic, you are going to use IV dose. So initially you are going to give 6 gram IV infusion over a period of 20 minutes, and then a continuous infusion of 2 grams per hour. Right? So initial dose has to be 6 grams IV, which you have to give over a period of 20 minutes, and then you have to give a continuous infusion of 2 grams per hour. Right? Now, a very, very important question is, what are the overall contraindications for using tocolytics? In what conditions tocolytics as a general group should not be used? Right? So number one, whenever there is any lethal fetal anomaly. Number two, if there is intrauterine death of the fetus, or if you are getting non-assuring fetal heart rate status on CTG. Then if there is maternal hemorrhage with hemodynamic instability. So if mother's vitals are hemodynamically unstable. Right? Then if dilatation of the cervix is more than 4 centimeters, that means now there is no use of tocolytics, because this patient will ultimately deliver. right? If there is preterm premature rupture of membranes and there are high chances of cord prolapse. So when I'll be talking to you preterm premature rupture of membranes, one contraindication I'll tell you is that if the head of the baby is not engaged and preterm premature rupture of membranes has happened, then there are high chances of cord prolapse, and that is a contraindication for using tocolytics, and if there is chorioamnionitis, right? So if the fetus is abnormal, how can fetus be abnormal? If there are any congenital lethal anomalies in the fetus, IUD in the fetus, or if there are non-reassuring fetal heart rate status, or if mother is not well, so if the mother is hemodynamically unstable, right? Or if mother has got chorioamnionitis, if there is preterm premature rupture of membranes in such a manner that there are high chances of cord prolapse, right? Or if dilatation of the cervix is more than 4 centimeters, in these conditions you should not be using a tocolytics, right? Please remember, patients who are in acute preterm labor, they do not benefit from progesterone supplementation. Progesterone is a method to prevent preterm labor. It is not a method to treat preterm labor. It is not a tocolytic, right? Then bed rest. Bed rest is not a method to treat preterm labor, right? Sedation. Sedation is not going to help these patients. Hydration. IV fluids is not going to help them. And antibiotic therapy for subclinical genital infections. So you are going to give antibiotic therapy for GBS prophylaxis. But for treating subclinical genital infections, that's not beneficial, right? So these things are not beneficial in patients of preterm labor, right? Now, I also told you this, that if you have a patient of preterm labor who's coming to you between 24 to 32 weeks, then you should be giving magnesium sulfate for neuroprotection, right? Over here, I told you this. So, just now I told you magnesium sulfate is not used as a tocolytic. It's not a very good tocolytic, but for neuroprotection, yes, I have to give magnesium sulfate. And this is one very important short note which can be asked to you. They can ask you the role of magnesium sulfate for neuroprotection. So please remember, what is the mechanism of action when it is being used for a neuroprotector? It stabilizes cerebral blood flow, number one. Right? Number two, it blocks excitatory neurotransmitters like glutamate. So it is going to prevent any excitatory injury. Number three, it has antioxidant effect, and so it prevents oxidative injury. Number four, it has anti-inflammatory effects, so it prevents inflammatory injury. So these are the four mechanisms by which it is going to act. It is going to stabilize cerebral blood flow, right? Number two, it is going to block excitatory neurotransmitters like glutamate, and so it is going to prevent any excitatory injury. It has antioxidant effects, so it prevents oxidative injury. It has anti-inflammatory effects, so it prevents inflammatory injury. So the overall effect is it decreases the chances of cerebral palsy in the newborn. It decreases the risk of severe motor dysfunction in the newborn. But it has no role in decreasing intraventricular hemorrhage. It has no role in decreasing stillbirth, right? And it has no role in decreasing white matter injury of the brain. So it has got no role in these things. No role in decreasing intraventricular hemorrhage, no role in decreasing stillbirth, and no role in decreasing white matter injury of the brain. It has a role in decreasing cerebral palsy in newborns, and it has a role in decreasing severe motor dysfunction in newborns. Then it has to be given between 24 to 32 weeks. And what is the dose? See, for tocolysis, I told you, you have to start with 6 grams. But for neuroprotection, you have to give 4 grams IV over 20 minutes and then an infusion of 1 gram per hour. Tocolysis, it was 6 and 2. And for neuroprotection, it is 4 and 1. Maximum you have to give for 24 hours, and you are going to monitor urine output of the mother. You are going to monitor her respiratory rate and her deep tendon reflexes. DTR is deep tendon reflexes. Contraindications are same what I told you just now, that you are not going to give it if there is myasthenia gravis, you are not going to give in cardiac conduction defects, and you are not going to give it in cases of myocardial compromise, right? So this is all what you need to know on preterm labor. Okay, so I hope you people have understood preterm labor and you have taken down notes on preterm labor. For theory purpose, this is more than enough. For Viva also, they are not going to ask more than this, right? Now, for your NEET super speciality exams, I want you not to remember the pathogenesis in detail. Rest, the doses of tocolytics, the indications of corticosteroids, everything else is very important for you. Okay, so now again, my request to you is that if you are liking lectures like this, please do not forget to press the subscribe button and the like button, and do not forget to share this video with your friends, and do not forget to write a comment in the comment box so that I know what extra things do you need. If there is anything else which you want me to do, during these lectures, let me know that. If there are any topics which specially you want me to tell you in these lectures, let me know that those topics also in the comment box, right? So the comment box is going to be a way of interaction between us. Also, you can subscribe to my Instagram handle, Dr. Sakshi Arora Hans, Obs and Gynae, and we can interact there as well. Take care and keep studying and keep treating your patients well. Bye.